Thank you so much. It's a pleasure and honor to be back here. As Cassandra had mentioned, almost 4 years ago on November 4th is when I left Connecticut. So I was here on the board of directors for 2 years, or for just a year. It was just a year. We're here in chapter 070, and so again, it is a distinct pleasure and honor to be back. Who else here from UConn? Show of hands. That's right, all the UConn people, yes. That's where I work. I worked at UConn at John Dempsey, so again, my name is Charlie. You guys may have seen me during lunch. I am your chair of the National Nominating Committee for APRN, but I'm also involved in other ways. One of my passion areas has always been surgical missions. And it's not a passion that I found, it's a passion that found me. This presentation is structured more like a scrapbook. So I hope for those of you, especially after lunch, you guys won't fall asleep. There'll be a lot of laughs, a lot of little giggles, a lot of little things here and there, little Easter eggs in here for you. But I hope that this gives you a perspective into surgical missions that I think many of us lack and don't really understand when it comes to nursing or perioperative missions in a different country, in a different region. First and foremost, I have no disclosures, no financial interest. The only disclosure I would have is that I'm actually on the board for a surgical missions agency based out of Dallas, Texas. Objectives for today, it's an academic session. I'm gonna have to cover some content, I'm sorry. But first and foremost, we're gonna describe the history of medical missions in the 18th to late 19th centuries. We're gonna talk about a few nurses that were involved in early medical missions in that time frame, describe some of the 5 ideal characteristics of volunteers participating in humanitarian surgical missions, describe 4 ethical considerations for participation on surgical missions, and finally, explain 4 ways on how to get involved in humanitarian surgical missions. First and foremost, we're going to play a video. This video, you will find out, is the reason I got involved in surgical missions.
Dr. Drew, I was sitting here, we want to show you something. Probably seen this guy all over your feed claiming that cutting carbs is
not cutting carbs, though. Not why.
Landmark program is a gift of love.
Be on the lookout for
those people who recognize a person, particularly a child with a very severe facial deformity. Leanne was a very unique and difficult situation. She had a cleft that went through her lip, her palate, her nose, her eye socket, and into her brain cavity. Her eye socket was severely displaced. Her nose, she had 4 segments of 2 noses. So it was a very rare condition that I don't know if there's ever been one exactly like hers or not.
My name is Jane Lannon, and we are the host family for Being, visiting from China. She's very special to all of us. She's been coming to Dallas since she's been 5 years old for surgery, and we're just happy to be a part of being able to host her. Being at with Mom has been really interesting. I was a little nervous about it at first, just because I didn't know what it would take and with the difference in language, but it's actually been really special. We've been able to communicate back and forth, even though we don't speak each other's language. You just make it happen, and it's actually just really special. We've become very fond of one another.
Seeing my family be involved over the years, we've hosted several patients through Lead that have been treated by Dr. Moore. It's been neat to see them get involved because they're not necessarily medical. My grandfather has worked with Dr. Moore for years, and that's how I was introduced to Lead. Subsequently, I went on a trip with my mom, and now Abby and I are involved in Practitioner right now. It's cool to see Lead involved with 3 generations of our family. Hopefully more to come. I think this shows anybody can get involved with this kind of work. Got to work hard.
怎么认识你？有的人特别不让校园人讨厌他们，让到地方。因为要对我们30多年的时候，这么好的语言，然后教会，然后 我们跳学会，然后每天都给我们安排的时间，然后我们怎么忙，还有。
So the 25th gala was several years ago, just FYI. That's not this year. So this is the story of Li Ying. So very few of you guys may know this. My career as a nurse did not start out in ER. My career in nursing was very similar to Melanie's story. I came out of nursing school. I was interested in OB. That's where I excelled.
Top 3 tips on starting an essay.
We're not talking about essays either, or watching music videos with Drake in it. Here we go. All right. So I came out of school. My last semester in Practitioner, I was slated for trauma. So I finished my practicum semester in the ER in a level 2 trauma center. When I finished, thought ER makes sense. You get to play with toys, you're very skilled, you think on your feet, you're very, very much independent. And that became my world. And I thought that was basically where my career was gonna go. Then in church one day, a couple of friends in my small group have reached out saying, you know, we are looking for someone who can translate, who can be an interpreter for Chinese. And 2 of us looked at each other thinking, you realize you just asked this in an Asian American church. Keyword emphasis on the American. So there were only 2 of us that were looking at each other thinking, maybe, but neither of us can do medical. Now, Chinese may be my first language, English may be my third, but even then, I don't think that I have the skill set to translate medical Chinese. But, you know, kind of interacted through a friend who had asked, reached out and said, I can give it a shot. I can see what happens. And so I ended up in a Ronald McDonald house a month later. There was a child there. She was 14 at the time. She had just come from China and already had 7 surgeries done to her face. In normal surgeon fashion, the surgeon was not there. He showed up 2 minutes before the video. I had 0 time to say, hi, my name is Charlie. I am your interpreter for today. And we just went straight to the live news interview. I was thinking on my feet, this is live? Shoot. What if I translate wrong? It's like, oh my gosh, everyone's gonna look at me like, why is this translation so horrible? So I had no time to kind of prep for this interview, and the interview went on for about an hour. And in that interview, I got to learn about the story and history of Li Ying. So this is when she was 14. This is not her 14-year-old picture, by the way, but I met her as a 14-year-old, and in that 1 hour, my mind was blown. I had never thought about surgery as an option, but in hearing the story, her trajectory, and just kind of how everything happened, it opened up a whole new world for me. I had learned in nursing school that the circulating or the perioperative role had the nurse sitting in the corner, as best nursing students learn. And so that's why I had no interest. But at the end of the interview, Dr. Hobar came up to me and said, hey, my name is Dr. Hobar. It's so nice to meet you. Thank you for being here. What is your name and what do you do? My name's Charlie. It's so nice to meet you. I'm still crying on the inside. But I told him, like, hey, I'm a trauma nurse at Baylor. So that's where I grew my ER training. And said, hey, you know, I'm so impressed with what you're able to do and how you have an organization that flew this girl out from China so many times and has continued to do all this work to take care of her and to give her a better life. That wasn't the last time I saw Li Ying. I saw Li Ying for multiple trips thereafter, including that video that you guys just saw. So if you saw the little person, the shadow walking around, that was me. But I got to be a part of this girl's story. And from that opened up a new perspective on what perioperative nursing really could be and what it looks like. So we're going to talk a little bit about some of that. So we can't talk about surgical admissions without talking about the medical aspects of it. Medical admissions was really, if you look at the literature, really started in the late 18th to 19th century. This is more in the European countries at that time when you would see it. If you got sick, what did you do? You went to the church, you went to the parish and asked for healing, because sickness and illness at that time was very much associated with spiritual health. So if your spirit is good, your health is good. If your spirit is not good, you're probably going to be sick. At the same time, there was a lot of conflict on what the definition of illness was. Because if God says you should be sick and you should pass away, well, that was God's will for you. Why is man to be the one to change that fate? So because of that, people would live in different cities, different places where they would be a little bit more rural. They wouldn't have access to a church. You would have to go days and days and days, miles away to find a parishioner who would be willing to see you and even give you any, spiritual healing, much less physical healing. So because of that, there was different modes of treatment, conflicting understanding of what constitutes human wellness, as well as what those treatment plans were. There was nothing in the text, there's nothing in the books. People were just kind of flying by the seat of their pants. Because of that, there's also ethical and theological issues as to how or if treatment should be paid. Right? If you go to a church, at that time you gave an offering. You did something to benefit the church. That also created a lot of confusion on what's the role of the hospital, because of course, hospitals may be even further away, may even have less access to it. And because of that, what's the role of women? Now, I'm looking around this room. What's our ratio of females to males, right? As far as nursing staff, right? Let's see that. And that's exactly the same with how it was back in the day. You went to the church for healing, you went to a hospital, most of that care was probably offered by male clergymen. You wouldn't typically see a female clergyman. Then the other problem is language. Say that you live in one country, but your nearest parish, your nearest church was in the whole next country over. That's going to get really messy if you're trying to go up to a person who doesn't understand your language and say, I'm sick, please heal me, right? That's really challenging. And then because of that, as I mentioned, there's a need for medical training. There's no consistency. People would go to churches and the churches would try to do their best to heal them. Reverend John Lowe, who was the secretary of the Edinburgh Medical Missionary Society, had wrote, natives almost everywhere have a kind of intuitive knowledge of the medicinal virtue of indigenous plants, and although they are, as a rule, utterly ignorant of the diseases they presume to treat, yet much confidence is placed in the native doctors and their nostrums. And somehow, they do at times appear to effect wonderful cures. But they can do nothing whatever in surgery, even in the simplest cases. There was no knowledge sharing. Now, think about today. You're here at Period Connect, right? We're interacting, we're sharing knowledge, we're learning from each other, right? Think about how life would have been at that time if they had thought about something like this. Now, again, we're at a nursing conference. I have to talk about nurses, let's be honest. So some of the famous nurses that were involved in medical missions, not necessarily surgical, but medical missions, are listed here. So I've highlighted quite a few. Florence Nightingale. Who here does not know Florence Nightingale? I think that this is so much drilled into the core of our primary nursing education. By the time you graduate, if you have not heard the word Nightingale, we have a problem. But Florence Nightingale had started the Nightingale Training School at St. Thomas Hospital in 1860, right? There was a need to create focused and centralized nursing education. Someone thought that that was needed, right? Then there's Linda Richards. She is who you guys may not know, may not be as familiar with. She's actually the first American trained nurse, our first graduate. As much as we talk about Florence Nightingale, if we want to look at the American studies, it's Linda Richards. Now, she's also the person that's credited with developing the need for individualized health records. How messy would it be if we did not have patient records? Oh my gosh, you would have no idea when this patient came in last, and what worked and what didn't work, and what surgeries they had in the past. You'd have no idea. Linda Richards was one of the people that made it a critical part of our practice. Then you have a few more individuals here. The countries that are listed in parentheses on the side is actually where they ended up spending most of their work. Realizing, again, this talk is about missions. They spent their time in many other countries affecting the world, impacting how nursing care is provided, and providing those resources from their training. And all of these nurses down here were American trained, minus Florence Nightingale. Then you also have Francis Piggott, who proposed that there was a need for the Colonial Nursing Association. And because of that, the creation of that association, they trained over 8,400 nurses in the United Kingdom. That's a lot of nurses in that time frame, from 1895 to 1966. Especially if you think about, how our graduation rates look today. Think about how much smaller those classes were back then to try to get that educational support and that foundation. So, all right, some of the boring stuff is over. Time to wake up. We're going to talk a little bit how this journey begins. So first and foremost, when you're doing a medical mission, you have to figure out, there has to be a need. How many people in here like to go to parties uninvited? You have to know that there's a need, because to go on one of these mission trips, there is so much legwork that needs to be done to prepare for that mission trip to happen. You need to have local contacts, you need to have financial backing. How many of you guys have passports? How many people have your plane tickets? There's so much that goes into the work and preparation of going on a mission trip. You have to know where it begins. So you have to find a reason and a purpose to go. Because of that, you need those contacts. And then more importantly, you also, as an individual, not as an organization, but as an individual, why do you want to go? Now, by a show of hands, how many people in here have gone on a humanitarian mission trip? So a few, right? Here's some of our ideal characteristics. For the 4 of you that raised your hands, hopefully these characteristics resound very true for you. But first and foremost, competency and clinical skill. Now, we are no stranger to competency. We're no stranger to skills checkoffs. This is both subjective and objective. Are you going to bring a perioperative nurse who just finished Peri-Op 101 on a mission trip? Probably not ready. Probably need a little bit of time. Because you have to build that competence, because when you're working in a different country, there's so many things that change. It's so difficult to practice American nursing in a different country because your resources are going to be very different. Your patients are going to be different. The stuff you're going to see, all very different. So it's very challenging to practice at the top of our American level unless you are completely prepared for it. Adaptability, flexibility, and innovation. Again, you're practicing in a place that's very different. If you have a nurse who's very rigid with how they practice it, that may become a challenge when you're out in another country and you may not have brought all the same stuff you use in your day-to-day OR. In the organizations I've gone with, I've had to pack everything that we need to bring. We rarely, almost never use the supplies from the hospital, which means if I didn't pack it, I don't got it. Awareness of our resources and conservation. Again, there are so many mission trips I've been on where my surgeons have said, oh, we forgot to bring this. We could just use it from the hospital. Hang on. Before you do that, are we taking away from the local supply? If we're using what they have in-house, how long is it going to take for them to get access to that same supply, especially if we deplete all of it? I will definitely tell you that when I've done, probably should have started with this. I have done over 35 mission trips, and I will be hitting 40 before the end of 2024. I already have 4 trips between January and June. I can tell you with all of these trips, it is that chaotic when you're trying to figure out what supplies to bring and what you need and what you don't need. When you do a case here, how many trash bags do we go through? If you go to another country and you do a mission trip, how many trash bags do they go through? A kick bucket. That's your back table, that's your sponges, your laps, your Ratex, your sutures, 1 kick bucket. Yeah, we go through gigantic bags of waste. So all the stuff that we bring from our ecosystem here in the States, we're going to bring all that to a foreign country and dump it all in their waste. That's stuff that we don't necessarily think about. But our surgeons expect to be able to do the exact same procedure, the exact same way here as they do there as they do here, right? But we have to think about that when we do mission trips and we're bringing foreign materials in and adding that to their ecosystem. Resilience to hardships and distractions. Expect the unexpected. You never know what's going to happen. I will tell you, So I work at Stanford Children's in Palo Alto, California. I am an ear, nose, throat nurse practitioner, otolaryngology, head and neck surgery, and I'm a first assist. I am an airway specialist on the pediatric service. I have not gotten COVID from the hospital. Every time I got COVID, mission trips. It's my gift. But you don't know what you're going to come up to, what you're going to encounter. So you have to be ready. You have to be ready to expect that unexpected. You have to be open-minded. You have to be sociable. You're coming into an area, to a hospital that's not your own, and you're like, hi, where's the trash? You know, you want to make friends, right? So usually when I go to my other countries, I'm like, hi, my name is Charlie, I'm the nurse. You know, I'm working with this team. Can you point me where the bathroom is? Can you point me where the OR that we're using is? Where's the area that we're going to use to set up patients, recover them after the surgery is done? You want to make friends, just be friendly. That's how you get invited back. And with that, you also need a sense of humor, right? Things can change from country to country, and their practices are very different. Great example is for Mexico, I go there twice a year to do microtia reconstruction. I'm a microtia first assist in my present job, which is ear reconstruction. But in Mexico, I'm the mission leader for that country for LEAP. And with that country, what is challenging is that our very first hospital we were in, there was something that I had never come across, which I was thinking APRN likely has never addressed as a practice standard. When you are trying to get a patient from pre-op to the OR, there's a pass-through half wall. So you have a stretcher on one side and a stretcher on the other side of this wall. And the patient crawls from one side over the wall into the bed. And then, so the OR nurse never leaves the OR area. Okay, you go to the receiving wall and push the patient in. Surgery's done. How do you think this patient's getting to PACU? And guess what? They're intubated. Who's excited? Yes. That was a practice at that hospital. And so when I asked them, I was like, are you serious? Okay, all right. Can we just move really slow so I can take off my booties? Because you also have to keep your booties on, but you can't wear your booties past the wall. So they must stay on. So the patient's already moving, but you're there trying to take off your shoe covers. Okay. The anesthesiologist that came on that trip, guess what? He didn't get invited back ever. So you have to be open-minded. You have to try to learn the local customs and practices, and that tends to be the biggest challenge when we go from one country to the next. So I can't go in this presentation without talking about what the heart of nursing really is, right? It's in the title. The heart of nursing is empathy, which we in nursing have learned very well what that means. So the definition in its own right is an ability to place oneself in another person's situation and look at their condition through their perspectives, emotions, actions, and reactions. Now, this in itself is very different from sympathy. Sympathy is an emotional response. It's a desire to see the patient free from distress and hope that they can overcome any obstacle. Although well-intended, it tends to be a pity-based response. Even in another country, your patients know that. They know the difference between empathy and sympathy. So you, as a person going on a mission trip, need to figure that out for yourself. What does empathy look like for you? What does sympathy look like for you? Because we have to be able to show our compassion for our patients. And they have to know, they want to know that we truly care. So that requires that we examine ourselves. There's self-awareness, there's that intuition. And before you go on that trip, set aside your bias. Identify what those are and then push those to the side. Be at the ready. Now, we also have to learn how to listen. Now, in another country, that may be a challenge. The reason that I'm the mission team leader for Mexico, ironically, in the organization I'm in, I am the only circulator who speaks Spanish. So because of that, I have been able to communicate and I can talk with the patients that we work with there. And because of that, I have a long relationship with them. The families know me, the patients know me. So every time I come off, you know, we are having a conversation. I'm catching up on life with them out there with me. And in doing so, we need to be able to express our own feelings and needs without sacrificing the integrity of our position. That's something I think a lot of times on a mission trip, you forget about because you're like, we're here, we're gonna do mission, we're gonna do work. we need to be able to have a non-biased opinion of how and if this patient needs surgery and what the outcomes will be, and make them so that the patient understands what those outcomes look like. And then because of that, compassion. Compassion is a relational and proactive response to suffering. But in order to be compassionate, you must have these 3 R's. You must first recognize, you must then relate. Now, relate doesn't necessarily mean empathy, it may also mean sympathy, but you must have thought through what that looks like for you as you work and talk with these patients. And then you have to be able to react. Now, it could be in a hug, if that's culturally appropriate. It could be a smile. The reaction is different. It's not necessarily something you have to physically do. It can be something that is nonverbal, unspoken. Now, the tough discussions, the tough things you have to talk about. Some of the less ideal characteristics of a volunteer. Someone with questionable motives. I have gone on mission trips before where afterwards the members of the team were more concerned about where they were going to go party, go to the club after we were done, then the work that was at hand. That made it very challenging if you're in the middle of the OR and you're trying to get through cases, trying to do the most you can and still know your supply. If the person in the next room is constantly out doing something that is not the work, or if they're trying to do the trip and come back and say, like, I'm a better person because I did a mission trip. Rigid expectations and inflexibility, that affects the morale. If you're not working well as a team, just like in our ORs here, how difficult is that on a mission trip when you don't know anyone on your team? Most of the teams I go on now, it's a 50-50, meaning 50% returners, 50% new. So more or less, I know most of the people on my teams, but when I first went on these mission trips, I didn't know anyone. That would have made it really tough for me to approach people if that morale was really low. Cultural insensitivity and bias, as I mentioned before, again, we have to have a worldview before we go to these countries and understand where are they coming from and how do we best relate and how do we meet them in the middle. If you don't have that awareness, it makes it really difficult for you to work well and interact with these families. And then extreme social behavior. Now, if the extreme introvert is the quiet person in the corner, you can't pull them out of the corner to work as part of the team, that's going to be a challenge. If you have the person who just won't stop talking, also really difficult to do your work. Now, a little bit about missions organizations, missions and volunteer organizations. Here's some of the things that a lot of people don't necessarily think about. In order to go, you have to have a mission and a purpose. So there's a foundation for the decision making. There's a foundation and purpose for why you go to a specific country, why you offer to do those specific cases, those specific surgeries. Then there's the authority or the legal framework. How many of you guys have a license to practice in a different country? Okay, so we have 1, 2, all right? So we have a couple of people that can practice in another country. How many of you guys can practice in every country in the world? Think about, for those that have been on mission trips before, how often have they verified your license in those other countries? Exactly. They are leaving it to that organization to vet you for that you are truly an active registered nurse to go on these trips. There's no international licensing, that doesn't exist. That also includes the surgeons that you're going with, right? So a surgeon may come, you yourself as a nurse are just trusting, oh, this is Dr. So-and-so, they're a surgeon. Really a surgeon? Oh no, right? Licensing and privileging, your scope of practice, again, that also varies. I will say in a lot of the countries I go to, a nurse practitioner does not exist. Yet, on my mission trip, several of my mission trips, I play nurse practitioner and do post-op rounds and round on patients. I go administer medications between and during and after cases. But I'm not a nurse practitioner in that country. What allows me to function in that capacity? Context and your scope of care. The mission's overall purpose, their priorities, and what limitations do they have? Do they have financial limitations? Do they have legal limitations? What things are preventing them from being able to do more in a specific area? So you have your personal mission and priorities, the mission trip itself, the trip that you're actively going on has its own priorities, but then as an umbrella, you have the organization as a whole. Is that organization achieving their objectives, all of their goals? It's very important. And then aligning your expectations. Your professional contact is very important. Again, we are visitors to those countries. We want to reflect ourselves well, want to be invited back. So play nice in the sandbox, please. Recognition and management of risks. Local customs and open communication are also very difficult. Again, language can be a challenge, but your local customs, like I just said, about moving that patient over that half wall. It's a very new experience for me. You know, that's not the first time that's happened. I had to circulate for 2 rooms side by side in 1 room before. One was a hernia case and one was a cleft lip. And I was like, who needs what now? And at the same time, the surgeon in the hernia room was passing out. So I was trying to do something for the cleft room, for the cleft half of the room, but kicking a sitting stool to the other side of the room so he could fall on the chair and not fall on the floor. And then telling the scrub, pack that so that it was husband and wife. Wife is a plastic surgeon, husband's a general surgeon. So she just said, is he okay? And I was like, yeah, he's fine, he's slumped over in the chair. All right, pack that up, I'll finish this cleft palate and then I'll come over and close the hernia. And you know, are you ready to be able to do that? Are you ready to be able to handle that? Adverse outcomes and complications. This is something that we also don't think about. We come in, we do our surgeries, and we say, bye. What's the follow-up for the patient? What happens if the patient has issues, right? Post-op complications. They can go for weeks, they can go for months. When's the next time you come back? If your mission trip comes once a year, better pray and hope that that patient does well for the next year. They don't have a defense. But you can have adverse outcomes because of an unfamiliar environment. What are the comorbidities within that patient population, within that patient group? And then unexpected post-operative complications, like I mentioned. For my Mexico, my Croatia mission trip, I do post-op clinic. Everyone comes back to America. I'm stuck in Mexico by myself for another 3 days. I do post-op clinic in the morning, and as soon as I'm done, I get on the plane and I come back to the States. But for every week after that, the primary surgeon and myself, we take turns on who does telehealth. And we just virtually see these patients and ask them families to send pictures and do management, and we just take turns. Because that's the only way that we can make sure that these ears are reconstructed well, that they look good once it's fully healed. But what would happen if the wound dehisced and we're both here in the States? I can't run over there and just go close that. I can't go suture it. She can't either. We have to hop on a plane, right? So you have to know your resources and your environment. Now we have ethical considerations, things to keep in mind, patient selection and informed consent. How many of you guys have participated in informed consent in a mission trip? How many of you guys have enough translators that speak that local indigenous language to truly do an informed consent? Also something to think about. Risk of equipment use and medications. I mentioned this earlier as far as the stuff that we're bringing in from the States to those countries. It's not indigenous to those countries. It's very difficult. So we're exposing these patients from other countries to stuff that they otherwise may not ever be exposed to. Are we ready to handle those side effects? Sterilization may also be very tricky. They may reuse glue wraps and tape all the time and not change the tapes out on the wrap. So you think what was sterilized, but once you start pulling the tape off, you realize the tape looks different from the other tape, and it's on a different side. Was this actually sterilized? Or if you actually end up doing Cydex. I do Cydex on the mission trips all the time that I'm there, because we don't have a sterilizer in all the countries we go to. Customs, expiration dates, bribes versus fees, that's also a big issue as well. A lot of the countries that I go to are very corrupt. And so the customs people will ask for $1,000, $2,000 US to pocket themselves and not give to the government, but just to pocket, just to allow you to bring your surgical equipment in. But expiration dates, some countries have become more strict on it. I know our vendor reps, they're like, we're willing to donate stuff all the time, but is it meet a certain country's customs requirements? I know for Mexico, when I go, I have to make sure every single piece that I'm bringing in with my team is at least 1 year plus before expiration. So I can't bring anything that's expired at all, which makes it really difficult for our vendors to donate. And then local health providers. Again, finding and identifying someone locally to help you and to help manage in between makes a big difference. Post-operative management. We already talked about a little about complications versus adverse events. And then the medical system capability. Can they handle the cases that you just did? Perfect example is when I go to Mexico, I go to Zihuatanejo. And over there, there's no microtia ear reconstruction specialist. So if something happens, we send the patient to the hospital, the local doctor like, what is this? Is this a burn? What is wrong with this ear? Oh, there's some stitches. Oh, what? I don't know, like, let's do a skin graft. No, do not put a skin graft on that ear. It's already been reconstructed. There's already flap on it. Stop, don't do it. But they don't know that because they don't have that in their training. Cultural variations, we talked a little bit about that as well, as far as practice norms, legal prohibitions, things that you can and can't bring. And then the question for yourself is, do I have what it takes? Jokingly earlier, I'd asked about passport. It's kind of important if you're going to go to another country, you might need a passport. Credentials. Some organizations will verify, which they should, verify that you truly are an active RN. You have to give up your license to show them that you truly have an active license, you are who you say you are. If you need a visa in certain countries, even if you're going for a short term, you may need to research that. Are you in a good state of health to be able to make that trip? Example for me is going to India. When we go to Jabalpur, we fly from the States, we fly to either Germany or New Delhi in India, and then transfer. Once you get to New Delhi, or sorry, you go to Qatar and then you go to New Delhi. But once you get to New Delhi, you have to go from the international terminal, put all of your stuff on a Greyhound bus, go to the domestic terminal, which is a mile away, and then recheck everything in. It's a 1-hour flight south. Once you get to Jabalpur, it's a 3-hour van ride with no AC. Think about, can your body handle that? All right, so things to consider as whether or not you're in a good state of health. You might need your vaccinations updated. Now this is becoming less of a thing. In the middle of the pandemic, COVID testing was very important to have. And then your own medications, if you take pain meds, your regular medications, antidiarrheals, antibiotics. Here's just a sample logistical timeline of kind of like what a day in the life of a missions nurse might look like. So it's a pretty busy day. Breakfast at 6:30, devotionals at 6:50, leave for the hospital at 7 o'clock, get there at 7:30, try to get the first patients in the room by 8 o'clock. First starts is truly a thing. And maybe if you're lucky, bedtime by 9. Here's a testimony from Lead Global Missions from our first trip to Mexico. This was my statement that I gave for the annual catalog. I'll just read it. The bottom half is, what touched my heart was the patients that were in packing, caring for each other. Our last patient of the day was feeling uncomfortable, but needed to eat something with her medication. While we were trying to find crackers for her, another patient willingly handed the rest of his crackers to her. This definitely demonstrated the heart and compassion of Mexico's people to willingly just care for each other. They're absolute strangers. But he thought we were looking, and he just said, here, have at it. Please have my crackers. So how do you get involved? You don't have to be a nurse in all of these roles to be able to volunteer. I say surgical missions because you could do it from where you live here. You don't have to go international. Not everyone has to. If you're, a surgeon, anesthesia specialist, a nurse, a physician assistant, you may have the ability to go abroad and go on these trips. A lot of these organizations may also bring non-medical volunteers to basically act like child life specialists, which is a great job. As well as a lot of these countries, a lot of these organizations may have a local warehouse. If you get a lot of donations, someone needs to have gone through it. And that's another way to volunteer to give back, is to be able to go to the warehouses, help with packing and unpacking. Like I mentioned earlier, my start in this organization was by translation. So if you speak another language, that may be another opportunity for you to help. Host a family. The Lehman family, as you saw in the video from earlier, they were the host family for Lee Ying. Fundraising. You see cupcakes on the side. I used to be a frequent volunteer for Cupcake Camp for Dallas, and all proceeds benefited this organization that we made. But I just hosted a table and just told people all about the work that we do with our organization. Just tried to, garner support, bring awareness, and if they're medical, like, could consider coming if you want. put in an application. You never know how it goes. Event planning, again, that's also with the organization as well. But then financial support and sponsor. You know, I think Amazon Smile I should probably take off now because most of that's going away. But you can also do one-time or ongoing donations. You don't have time for Peter's story. This video is a 10-minute video. But you can also find it if you're interested in hearing about his story. It is also on YouTube. If you look up Leap, you might find the story on Peter. But that's pretty much the premise of my presentation. So what I would want to share with you about this photo is in my statement that I gave about the boy who handed his crackers, it is this guy over here. So this first picture on your far left, that's his first surgery. This is the second surgery. That's 6 months later when I came back and saw him again. This last photo was the last time I got to see him, which was in in December, when he finished all of his surgeries. And then that picture on the top is when I just got to see him in June. So because of the work that we did, because of our outreach, because of our interactions, he is actually in physical therapy school in Mexico because he wants to take care of patients, just like we were able to give him a better quality of life by reconstructing his ear so he's not so socially conscious of his outer appearance. So when we think about medical missions, surgical missions even in general, there's so much that you can do. It doesn't limit yourself to having to physically leave the country. If you're physically not able, you can do stuff here even in the States. You don't have to physically leave. But if you're physically able, if you're interested and you want to grow that part of your practice and get that exposure, then again, keep in mind where you are at. Can you physically take the time and effort to go to these countries? So thank you so much for letting me share my little scrapbook with you guys. And if you have any questions, I'm absolutely happy to talk to you guys in the back. But thank you again for having me back, and it is a pleasure to be back here in Connecticut.
Thank you.